Good afternoon. My name is Kristen Yowit, and I'm the Marketing Manager for Pharmacy and Vaccines at Helmer Scientific. I would like to welcome you to today's webinar titled Back to School, Navigating Return to School and Work Amid COVID-19 and Flu Season. Please feel free to submit questions during the webinar using the questions pane. We'll have time to answer questions at the conclusion of this presentation. I'm very pleased to introduce today's speaker, Dr. L.J. Tan, who currently serves as the Chief Strategy Officer of the Immunization Action Coalition. Prior to joining the IAC, Dr. Tan was the Director of Medicine and Public Health at the American Medical Association. Dr. Tan co-founded and currently co-chairs the National Adult Influenza Immunization Summit, as well as serves on numerous national and international expert and technical advisory committees and boards. Dr. Tan has received several awards for his advocacy work, including the 2011 CDC National Center for Immunization and Respiratory Diseases Honor Awards, Excellence in Partnering Recognition, and was recently awarded the American Pharmacists Association's National Friend of Pharmacy Award. Without further delay, I'm pleased to turn the presentation over to Dr. Tan.
Oh, thank you so very much for this opportunity to present to all of you, and welcome. I'm going to try to break this presentation up into several parts, and so in order to do that, let me just go ahead and get started and go through some of my disclosures. I have no conflicts of interest. And then I just want to remind everyone that this is a disclaimer on my part. The opinions that I present today are my opinions, and they do not necessarily represent the official positions for the Immunization Action Coalition, which is my employee, nor the National Adult and Influenza Immunization Summit, which I co-chair with the Centers for Disease Control and the Office for Infectious Disease Policy at the Department of Health and Human Services. So in that respect, it's important that anything I say today represents my expert opinion and cannot be construed or to represent the opinion of the CDC nor of the OIDP at HHS. So this is where I wanted to get to, and this is the outline of what I want to talk about today. And I know there's a lot of bullet points here, so I'm going to try to kind of make it a little bit easier for all of us. I'm going to just kind of talk about flu a little bit and talk about, some of the common things that we consider when we discuss flu and create flu messaging. Then I'm going to highlight the importance of not just flu, but adult immunizations in general. And the reason I'm doing both of this is to remind everybody here that this is what public health is focusing on this fall. This is going to be things that we're very interested in, very focused on as we move into the fall. And knowing that may, of course, help you understand some of your demands on storage and handling requirements for vaccines. Then I want to talk about, what we're trying to do in public health with regards to educating on co-circulating flu and COVID-19 diseases. That's a big challenge. That's going to be something that we're very, very concerned about going forward. And then finally summarize some of the CDC's messaging for flu, because I think that will help you understand also some of the things that are coming aboard in terms of how we're driving patients and providers to continue to keep up flu immunization, even in the context of delivering doses for COVID-19 vaccine. I will have a couple of slides just to remind us all about the new NSF standards for storage equipment. And then I'm going to have just one slide, in which case I'm going to open it all up and we're going to just take questions and answers on COVID-19. I'm going to do like little summaries and then take questions and answers for that. So that's kind of how I want to break up today's presentation. So without further ado, I'm going to go right into the 2021 influenza season. That's the season we just wrapped up. We're about to head into the 2022 season, right? And so I think we can capture it in immortal words that was uttered by somebody who's not that famous, myself, and that is season, what season? And I think this is a graph that I typically use every time when I give a flu presentation to show you how bad or to show you the profile of the flu season coming up. And just as an orientation, just to remind you, on the left-hand side is something called the percent of visits for the influenza-like illness. This is based on a surveillance network that the US has looking for influenza-like illness. And on the left-hand side shows you the number of visits that come into an outpatient setting for what we call ILI. And then on the bottom is the time frame in which those visits appeared. So as you can see, it's moving through the course of the year into and out of the flu season. And what you see on the graph are season data from the past 10 seasons of influenza. Most importantly, I want to highlight two seasons. The one in green, which you can see has 3 humps. The turquoise kind of green, that was the season that we just came out of. And as many of you will remember, this was a really interesting season in that the first hump was due to flu B, the second hump was due to H1, and then that third hump obviously was COVID-19 whacking all of us, right? The other thing I want to then point out, and it's highlighted by that blue arrow that points down, is this red line with the red triangles. That was the season that we just came out of. This was the 2020-2021 season. And as you can see, if that dotted line is the threshold for what we call epidemic levels for flu, you can see that for that season, we never, ever hit it. We just stayed below it all the time, basically showing us that we, like I said, what season? That being said, another thing that we do actually collect data on is pediatric mortality, just to kind of show you all this data. This is data from the last 4 seasons. And as you can see, we had 199 deaths in the season of 2019-2020. And then we only had 1 pediatric death in the 2020-2021 season. This reminds me to remind all of us that while we saw very little influenza, we did see influenza, obviously, in this case, resulting in 1 pediatric death. I bring up this for one very important reason. The reason I bring this up is I think that this is something that, we need help reminding our providers too as well. So any opportunity you all get to talk to providers, to the public, is pediatric deaths are totally preventable. And this is the problem, right? Because what we do know is that 80% of the deaths in the 199, the 144 the season before that, and the 188 the season before that, 80% of those deaths were because the kids were not immunized. So I always like to say that this is on us because influenza is a vaccine preventable disease. And in fact, deaths from influenza are vaccine preventable if we just vaccinated our children. So this is one of those instances where I think we need to do much better vaccinating our kids against flu. The other thing I'd like to remind all of us also is that flu has, while we all think about the kids and we think about the adults over 65, I bring up this graph, the one on the right-hand side, the bigger one, to highlight that flu also has dramatic impact on a population that's between the ages of 50 and 64. And I bring this up because I want us all to remember that the 50 to 64-year-old population is tremendously hit by hospitalization when they catch influenza. And the reason for that is actually quite simple. And this is what the arrow is there to show you. That pink line, or that little pink line of 50 to 64-year-old, the hospitalization rates in those adults are very close to the hospitalization rates that we see in those vulnerable children 0 to 4 years of age. So we want to make sure we don't lose track of these 50 to 64-year-olds. And the reason these 50 to 64-year-olds are vulnerable to flu and hospitalization because of flu is because of the fact that these adults have chronic conditions. More than 50% of adults 50 years of age and older are diagnosed with 2 or more chronic conditions. At least 20% are diagnosed with at least 1. So a total of 70% are diagnosed with at least 1 chronic condition that impacts hospitalization with flu. And this is what you see here. And that's the reason why Americans 50 years of age and older are a priority group for flu vaccination, because of the fact that so many of these adults have chronic conditions that predispose them to severe complications from flu. So I'm just going to highlight a couple of these, not to have you memorize anything, but the data is becoming clearer and clearer and clearer that influenza results in severe complications to people with cardiovascular disease. So that is one of those chronic conditions that we're trying really hard to get people vaccinated with. And that means, trying to work with the cardiologists to help them understand that they need to be recommending vaccine. And if they can't give vaccination, they need to be trying to figure ways to get vaccine to their cardiac patients, because influenza and cardiovascular disease don't mix. It's really, really bad. And then the other chronic condition that I want to kind of talk about is diabetes. Again, like cardiovascular disease, but just a little bit behind in terms of the data coming out. People with diabetes have dramatic complications when they catch influenza. And just that first bullet up there, more hypoglycemic events, increases in pneumonia, sepsis, coronary heart disease up to 4 weeks after an influenza infection. So I think it is clear the data is beginning to accumulate that diabetes and flu, like cardiovascular disease and flu, do not get along. And so we need to make sure that we keep thinking about how to improve our immunization coverage of these folks who have cardiovascular disease and diabetes. So moving along, that was my little aside on these high-risk people who get in trouble with flu. This is just another way to show you again what kind of flu we had. Typically, I would use this data and say, hey, look, look at the different types of strains of flu we had. We had the B strain, then the A strain, and so on and so forth. In this case, I'm just using it to show you one thing. If you look at the number of positive specimens for flu that were tested in each of those weeks at the bottom, right? Note the number. 100. So at the peak of our epidemic of our flu season last year, we were only getting no more than about 100 positive specimens a week. This is to be compared to tens of thousands when we have a regular flu season, right? So this again is to highlight how rare influenza was this past season. And so a quick summary of flu activity from the past season. What influenza? And as we all probably can guess, this dramatic decline on flu, impact on flu was because of the social distancing measures, the masking that we did last year, the potentially increased vaccination rates. We think we actually bumped up vaccination rates just a little bit. And of course, all the improved hand hygiene and infection control we did because of COVID-19. All of that resulted in this dramatic decline in influenza. And so now I'm going to talk a little bit how well we did in terms of vaccinating people, right? So this is something that we all want to know, because obviously the more people we can get vaccinated, the better protection, better public health. And of course, for you all, it also gives you an idea of the demands on storage and handling that might be needed as influenza vaccination begins to progress forwards. So the CDC expects coverage data from the previous season to become available in October, so stay tuned. But what I want to remind all of us is that we continue to have a Healthy People 2030 objective for flu, which is that we want 70% of everyone to be vaccinated against the flu annually. So 70% of everybody vaccinated against flu. So then let's take a look at how we're doing, right? And I think one of the challenges is that I can tell you right away, except for certain populations, we are not doing well. And I will show you a little bit more of that data when I start talking about adults. So let's look at healthcare personnel, for example. One of the things we do know, and if these numbers show you what this graph shows you is the number of personnel in a specific setting that gets vaccinated. And what we do know with healthcare personnel is that when you have an employer policy, such as a requirement to get vaccinated, which you see on the extreme left-hand side, 94% of the personnel in that facility get the flu vaccine. When you do something like on-site vaccination that's offered at least more than one time, it goes down to about 89%, but you're close to that 90% mark that we're trying to hit with healthcare personnel. If you just do it once, it's about 75%. But if you go all the way to the right where the facility does no requirement and has no promotion, there's only 52% of the healthcare personnel get flu vaccine. The reason I put this up is to show us the importance of some kind of employer policy to get people vaccinated against flu in healthcare settings. And this is also the same reason why you'll see a lot of healthcare settings moving towards COVID-19 employer policies as well, because as with flu, COVID-19 is a serious illness that impacts a lot of patients, impacts a lot of healthcare workers. And so in order to get to that 90+% coverage rates, it is clear from our experience with flu that you need to also have COVID-19 employer policies such as requirement for vaccination in order to get to that high protective numbers. Just to show you some of the work we've done on this, IAC actually has a website where we could do an honor roll. If you have an organization if you're an organization that has a requirement for vaccination for flu and your coverage rates among your healthcare personnel get over 90%, we offer them a certificate to put them on the honor roll. And what I do is to show you this honor roll and to show you that we have more than 1,150 organizations. So these are hospitals, clinics, long-term care, et cetera, who are now on this honor roll. What this means to us is that it can be done. A requirement for vaccination in order to work in a healthcare setting is indeed accepted. It is ethically and morally proper. And indeed, more than 1,150 organizations are on this honor roll, showing again that it can be done. So I think this is one of those things that I want to emphasize as we go forward and we talk about obviously COVID-19 mandates for healthcare workers. The other thing I want to point out to everyone is that the other place where we're really trying to focus coverage improvements on is pregnant women. And the reason for that is pregnant women actually do have very severe negative consequences when they catch influenza. And so we want to work really, really hard to get pregnant women vaccinated. And one of the things we do know is that in order for a pregnant woman to get vaccinated, it is fundamentally important that we have a strong provider recommendation. So for all of you who, as you work with your providers, helping them understand that if they recommend and offer flu vaccines, so in other words, if they carry the vaccine in their offices and then offer it and provide it, the vaccination rates goes up dramatically as compared to obviously a provider that recommends it, which is that middle bar, but does not offer it. That coverage rates drop by 25 percentage points. And of course, any OB/GYN provider who does not recommend flu vaccine, you can see the coverage rates drop to 20.6%. So clearly that strong provider recommendation and offer of vaccine is very, very important to get pregnant women vaccinated. And the reason, again, we focus on pregnant women is that we now know that there are a lot of high risk conditions that happen when you're pregnant if you catch influenza. And these are just some of those high risk conditions that we see, right? Increased risk of hospitalizations, increased risk of complications such as death, including death, right? And so I'm not going to go a lot into this, but just to reemphasize that these high risk conditions such as pregnancy is extremely not something we want to get with patients, right? So with flu. And so there's a recommendation to take a look at that beautiful meta-analysis that's shown at the bottom from Sonia Rasmussen at the CDC that summarizes a lot of these high-risk conditions for pregnant women and influenza. And so that's the reason why we spend a lot of time focusing on pregnant women as well. So I'm just going to wrap up with this summary slide to just kind of show you some of the thoughts I have with regards to where we are with flu vaccine coverage. Clearly, we are still well below that healthy people 2030 goal, right? So, and we need to do better. And in particular, our adult immunization coverage rates for flu continue to lag. And as I will show you shortly, this is reflective in general of our poor performance with regards to adult vaccination. We do see that steady improvement in the pediatric population, although the impact of COVID-19 on coverage rates in children remains concerning and something that we continue to work in public health to get back to, right? We keep emphasizing, got to give those routine vaccinations, got to give those catch-up vaccinations, even as COVID-19 is continues to rage. Our coverage in 65 and older remains unacceptably poor. And as I told you, with the high-risk adults, which is a vulnerable population, the coverage in that high-risk population also is unacceptably low. Again, we need to work hard to sustain our pregnant women, make sure that coverage rate stays at that 60% and continues to improve, recognizing again that strong provider recommendation does indeed make a difference. And then that healthcare worker coverage rates is likely to stay high. We know that flu vaccination with all those mandates that are now coming in makes a difference. We still are working with the long-term care facilities. That tends to be the one place where our flu vaccination coverage for healthcare workers remains unacceptably low. And so we're working there to try to get them up to 90% as well. So that's a quick summary of some of the coverage issues that we're seeing with flu vaccine. And then, as I've already hinted to a couple of times now, I don't want us to forget about adult vaccines. There is indeed a now strong need for us to kind of remember, as with pediatrics, because of the impact of COVID-19, we need to remember our adults as well. And so just a couple of slides, I'm not going to spend a lot of time on this, but to remind all of us is that because we have such a good pediatric program, a lot of the burden of disease in terms of vaccine preventable diseases are actually among adults. So here's some numbers for pneumococcal disease. Here's some numbers for whooping cough. Look at those numbers in the adults. Here's a number for hepatitis B infections in adults. Again, vaccine preventable is the key word. Vaccines will prevent those almost 21,000 estimated new infections of hepatitis B. Vaccine preventable, again, can prevent almost most of those 1 million cases of zoster a year. And I put the measles up there to remind us of something very interesting. Many of you may remember or recall the measles outbreak in California that spread to more than 8 states in the Western region. And many of you recall that I call it again, non-offensively, I call it the Disneyland outbreak because that's where it started. You'll recall that California, as a result of that outbreak, successfully eliminated the philosophical exemption in their state for vaccinations. And so people keep thinking, wow, that was great, and we eliminated all those pediatric philosophical exemptions. That's fantastic. But what's really ironic is that if you actually look at the data, 55% of those outbreak infections were actually in adults. So I think sometimes I use this to remind us that we don't pay enough attention to the adults in terms of those coverage rates. And then, of course, we're talking about flu. So here's the burden of influenza from flu from the last 10 years. And as you can see, significant illnesses resulting in obviously care costs and burdens, hospitalizations, a tremendous amount, again, depending on the season. And then at the top of the pyramid, don't forget that flu does indeed kill. So again, a tremendous burden of flu as well. And then if you look at this coverage rates on the right-hand side, the graph it shows you coverage rates of all these adult vaccines. And I want to point out that most of them are below 60%. And if you look at the right-hand side and you look at the highlights in that yellow box, you'll find that some of them are tremendously low. Pointing out things like, for example, hepatitis B with liver disease, which is a strongly recommended vaccine. It's only at 33% of people with liver disease actually received a hepatitis B vaccination. And that's just unacceptable. I think that's, again, a lot of effort now working to trying to help improve the immunization coverage rates in adults. So just to remind us all, not only were adult immunization coverage rates low to start with before COVID hit us, remember that when the COVID-19 pandemic hit us, it further reduced our coverage rates in adult immunizations. So now we have to keep in mind as we continue to work on adult immunizations, it's not enough to bring us back to where we were before COVID. We actually have to bring us above where we were for COVID, because we need to catch up all those people who've missed vaccinations, right, during this time of COVID-19. And the data is very clear. That's what these two slides show. I put links there for you to kind of take a look at it. Both of these presentations or publications look at the impact of COVID-19 pandemic on adult vaccinations, and both show dramatically that there was a very strong negative impact in terms of reducing coverage rates even further from what they were before. So we were really not doing well after COVID, and during COVID-19, we are doing even worse. And so as a result, the summit that I co-chair has issued a national call to action that you can see on this webpage. Many organizations support that call to action. Starting here, you can just see the A's. This goes all the way down to Z, and so there's more than 50 organizations that have now signed on supporting the call to action. If you represent an organization that wants to sign on and support this call to action, there's a link you see on this homepage that tells you to support the call to action. You submit your information, and we'll be happy to add you to the list of organizations that support it. You can see we've already got some big name organizations there. We've got the American College of Physicians, the American Medical Association is there, the American Medical Group Association is there. So we are looking for partners to support this and send this message out so that people can recognize that we have to protect all adults from vaccine preventable diseases. This shows you the CDC support for this. CDC has jumped right in and supported this as well, and they issued their own document on their letterhead supporting the call to action. And as part of that call to action, not only are we asking providers to remember that they need to focus on adults and get them caught up, we're asking them to also adhere to these practices for adult immunization that have been established in the standards for adult immunization practice published by the National Vaccine Advisory Committee back in 2015. So these standards, and we're pushing these out to providers, tell them they need to assess the patient at all clinical encounters for vaccination. So in other words, no excuse. Anytime you see a patient, you are supposed to look and assess their vaccination status. You're supposed to identify the vaccines that they need and recommend them clearly. You're supposed to offer them if you can. And if you choose not to offer the vaccine, you minimally have to at least refer them to another provider that you know will vaccinate them. And then you're supposed to document those vaccinations that have been given. So even if you refer them, when that patient comes back, let's say you're a cardiologist, we're asking these cardiologists to say, you may not have given flu vaccine, we would want you to, but if you don't, you need to make sure you document that Mr. Smith, who you referred, actually got that flu vaccination. And then finally, obviously measure, we would ask that these providers measure their own vaccination coverage rates so that they can keep track of how well they're doing as well. So this call to action is very specific, provides a lot of clues to the provider on how to improve their coverage rates for adults. So we're hoping to see some yield in the next year or two where we hope to see these adult immunization coverage rates continue to climb up again. So the other topic that a lot of people want to talk about and want to hear about, and is something that's of strong interest in public health, is vaccine effectiveness for flu. So I'm now going back to flu a little bit. And to remind everybody that because we didn't have a lot of flu last year, we didn't have enough data to make a vaccine effectiveness estimate. So what I'm going to show you on this table is actually the data from the previous season, the 2019-2020 season. And again, reminding everybody in that season, for all ages, vaccine was about 39% effective. And one of the things I want to point out, what public health is trying to drive home to a lot of providers and to a lot of patients, is that this 39% represents number of cases of flu prevented. So it's about preventing disease. You do not catch influenza. That's the 39%. One of the things I think that's lost on a lot of people, and I think hopefully COVID will, and you can see the COVID messaging has kind of taken along the same lines of what we're trying to do with flu messaging, is that we want to point out that it's not just about preventing actual illness, it is also about preventing all those other negative outcomes as a result of that disease, be it COVID-19 or be it influenza. And this is actually effectiveness against hospitalizations and outpatient visits in adults. And as you can see, again, for any influenza, the vaccine was about 41% effective at preventing hospitalization and about 36% effective at preventing outpatient visits. So not only does it prevent infection, it also prevents hospitalization and it prevents outpatient visits, something to kind of keep in mind. And again, it gets even better when you look at the kids' data. If you look at pediatric influenza immunizations, hospitalizations and emergency department visits, you can see that the vaccine was 62% effective at preventing a child from ending up in hospital, which is tremendous. And you can also see it was about 56% effective at preventing a child from ending up in the emergency department. So again, another wonderful way to prevent that surge to our health system capacity, right? So I think what we're trying to do very much so now is to remind everybody that while vaccine, as you can see in that top bullet, does indeed provide protection against disease itself, preventing infection, it is fundamentally important to remember that vaccination offers significant protection against hospitalizations and other negative impacts from flu. So in other words, we want people to remember it's not just about preventing disease. If you get vaccinated and you catch flu, you will be much less ill, and you will be avoiding a lot of the negative impacts from flu, as can be seen by this infographic that CDC puts out every year. It looks at the number of benefits of flu vaccination and look at the number of cases prevented, the number of hospitalizations prevented, and the number of deaths prevented. Right? So these are all other ways to look at flu vaccine effectiveness that we're trying in public health to help people understand. It's not just about preventing disease. It's about preventing all these negative things. And one of these negative things is indeed what we like to call quality of life. So when I talk to people over 65 years of age, a lot of them don't say to me, hey, LJ, I'm really scared of dying from flu. A lot of them actually say to me, hey, LJ, what I really worry about is I have this great life right now. I cook my own meals. I'm in assisted living. Once a week, I get on this shuttle bus. It takes me to the local grocery store. I get to shop with my friends. It's awesome. I have a wonderful time. And what they don't want to do is they don't want to lose that. And what this graph points out is that there's a frailty index that we measure for those who are over 65, starting at the very top, where you're basically ambulatory, to very bottom when you can see, obviously, you're either with a cane, you're either in a wheelchair, or heaven forbid, you're actually in a hospital bed, right? And so one of the things to remind all of us is that as we age, multiple morbidities, those chronic illnesses, as well as something called inflammation, which is this higher systemic inflammatory response in our body, begins to go up. That begins to drive us down this frailty curve towards that bottom of the curve where we don't want to be, right? And so if you add on top of that influenza, what happens then is that it just increases that burden and you slide down that curve much faster. So you do not want to add influenza on top of all these other things that are already beginning to pop up, because it will just bring you down this curve much faster. And what I like to tell people is that if we keep telling our older adults that we want you to exercise, we want you to eat well, to not smoke, because we want to keep you going up this curve. We don't want you sliding down this curve. We want you up this curve. One of the things we need to add to that conversation is, of course, influenza vaccination, and indeed all appropriate adult vaccinations for this older population, because we do not want them to get an infectious disease that we could have prevented with a vaccine and have them go downhill and go downhill fast. And indeed, when I talk to people over 65 or to providers who take care of people over 65, one of the things I always mention is, are you willing to risk your independence this winter? So I'm going to talk a little bit about the flu vaccines that are out there. I think many of you probably already know this. So these are our new vaccine strains. Both the H3N2 and the H1N1 strains were changed. Both the egg-based and non-egg-based vaccines have slightly different strains in them, but they're both represent what we believe will be circulating this upcoming flu season. This is a catalog of flu vaccines that's out there for all of us to use this upcoming season. IAC has this PDF available for you to download. And the reason I put that little green arrow there is to remind us is that this upcoming season, Flucelvax, which is the cell culture vaccine, has a new indication that goes down to 2 years of age. It used to be at 4 years of age. So lots of different types of flu vaccines now out there for us to consider using. The other thing that we have, this is entirely voluntary. This is done by the distributors, and we support it through the summit. It's called our Influenza Vaccine Availability Tracking System. So if you know any providers who's looking for flu vaccine because they've either run out or they didn't order enough or whatever the case may be, and they're looking to buy flu vaccine, the summit keeps this tracking system available. The distributors voluntarily tell us how much supply they have of all those different vaccines that I showed you up here. We put it into a spreadsheet, and along with the distributor's information, and then the clinician can just basically use the spreadsheet, call the distributor that they're interested in, and order the vaccine so that they can continue vaccinating. So please help us get this out there and let people know that we do have this tracking system that they can use to look for vaccine when they run out. So I'm going to wrap up with some thoughts about flu, and then I'm going to open up with COVID. Finish up with COVID. So these are the ACIP recommendations that have just been published on August 27th of this year. Again, not much has changed in terms of the broad recommendation. All people 6 months of age and older should receive influenza immunization. And they say very clearly there is no preference for any one vaccine over the other. Influenza vaccination should not be delayed to procure a specific vaccine preparation if an appropriate one is already available. They note that flu vaccine generally becomes available in July. However, they point out that optimal vaccination should happen by the end of October, preferably during the months of September and October. That being said, ACIP does point out that certain persons should be vaccinated earlier than September rather than later, and these includes children who are 2 to 8 years of age who require 2 doses of flu. So giving an little extra time by starting earlier allows you to get that second dose in a timely fashion. And then obviously women who are in their 3rd trimester of pregnancy, they need to be vaccinated right away and not to wait till September and October. Other parts of the recommendation, as I mentioned again, even though they say the optimum time to get vaccinated is September and October, ACIP clearly states that vaccination should be offered as long as flu viruses are circulating and an unexpired vaccine is available. And they note that vaccine administered in December or even later, even if influenza activity has already begun, is likely to be beneficial in the majority of influenza seasons. And the final recommendations you can see here. One thing that's new for this upcoming season that we in public health are emphasizing over and over and over again is that you no longer need to separate COVID-19 vaccines from other vaccinations. Current CDC guidance indicates that COVID-19 vaccines can be given with other vaccines, including influenza. So in other words, they can be co-administered without regard to timing. So you can do them and there are obviously guidelines, but you can do them in the same clinical visit. You can give flu in one arm, COVID-19 in the other arm. And what I like to say is, providers should be saying to their patients if they came in for COVID-19 vaccination, hey, you got your COVID-19 vaccination, but you're not done yet, you need flu. Or vice versa, if someone comes in for flu, you got your flu vaccine, but you're not done yet, you need COVID-19. So I think those are some of the things that we want to point out again in public health is that this season, co-administration is indeed okay. So I'm going to wrap up here a little bit and talk about what to expect this upcoming flu season. Flu will be back. I say most likely because as a scientist, scientists always never like to say absolutes, but flu will be back. In fact, a lot of the respiratory pathogens, for example, respiratory syncytial virus that disappeared, quote unquote, in last season are already coming back. In fact, many of you may have read news reports about the severity of the current RSV season. That being said, I have no idea how severe this next flu season will be. When you've seen one flu season, you've seen one flu season. But again, flu viruses and SARS-CoV-2, which causes COVID-19, will likely co-circulate. And as a result, there will likely be people that are going to get co-infected. And the presence of flu on top of SARS-CoV-2 Delta is going to not only make people really sick, it's also going to result in an increased burden on the healthcare system, much like what we've been talking about last year as well. So once again, we need to hashtag avoid the twindemic. We need to hashtag take flu off the table again. Right, so once, this is not new, I said this last season and I'm going to say it again. We need to have a strong, unified national message that we need to seek flu vaccination as well as COVID-19 vaccination, and that the overlapping high-risk conditions between flu and COVID-19 makes it critical that we continue to work hard to do this. And in order to do this, what we're trying to emphasize is that access points have to be varied, they have to be innovative, and indeed the good news is that we've learned a lot from COVID-19 on how to do mass immunization clinics. And the hope is that we will now be able to use these mass immunization clinics, not just for COVID-19, be it for third dose, maybe, excuse me, but also for influenza vaccination as well. A little bit of philosophy here about how we need to coordinate and provide that strong recommendation for vaccination. So I'm not going to spend a lot of time on this slide. I think we do want to continue to remember that all public health are in the same ship together. So we want to speak to the same messages, the same united messages, which is why I'm going to give them right now. So this is the CDC 2021-2022 flu vaccination messaging. First, influenza activity during the 2020-21 season was low, but with the relaxed COVID mitigation measures that we talked about, we're probably going to get flu this year. In fact, like I said earlier, RSV is already circulating, and so it is likely that there will be more widespread disease this fall and winter, and therefore getting a flu vaccine will be important to prevent flu. And indeed, CDC is stating that they're preparing for both flu and SARS-CoV-2 to co-circulate, along with other respiratory viruses, and anticipates that this will produce a renewed high burden on the healthcare system. They also recommend their three-pronged attack approach to fighting flu. You want to vaccinate, you want to treat with antiviral drugs, and then you want to make sure you continue to use those everyday infection control interventions, such as covering your cough, staying away from people if you are sick, and so on and so forth, many of which we implemented for COVID-19. And so CDC points out that in the context of the COVID-19 pandemic, local governments and public health departments may actually have additional infection control precautions. And if they do, they recommend, CDC obviously recommends that you follow what's happening locally as well. But again, I think it's important to emphasize this infection control, masking, social distancing worked to reduce flu last season. And if we do that this season, it will do the same, but it's unlikely that we're going to be at that same level as we were the previous season. Again, to emphasize many of the benefits that we've already talked about with flu vaccination, not just in terms of preventing disease, it prevents hospitalizations and deaths, prevents the burden on the healthcare system, especially as COVID-19 continues to surge with the Delta strain, importance of protecting pregnant women and those with high-risk conditions such as diabetes, heart disease, and chronic lung disease. All things I've kind of mentioned. These are some of the talking points that CDC will be using again with flu this upcoming season. And then finally, CDC reminds all of us that we need to work hard to target these high people. It's not just about talking, it's also about making sure we focus on these people with high-risk conditions so that we can get them vaccinated against flu. And they point out that in the past, 9 out of 10 people hospitalized from flu have had at least one underlying health condition, something that I pointed out earlier on with my little pie charts. And then finally, don't forget the kids. I already mentioned that. That's on us. When 80% of our pediatric deaths from flu are in unvaccinated children, that's our failure. And then finally, to remind all of us, for those of you out there who probably know this already, there is a vaccine storage committee, the NSF 456 Vaccine Storage Committee, that has come up with a new standard. And this standard was published in the summer of this year. Many of you are probably aware. And this standard was created to address that significant gap in vaccine storage criteria, and was a result of a partnership between CDC and NSM International, forming this storage committee to develop these standards. And indeed, I'm happy, and if you have questions about this, there are many experts here from Helmer who can obviously provide you some of that background and information as well. But these are all the groups that contributed towards that new vaccine standards that were approved and published in 2021. Okay, so I'm going to pause here, and I'm going to kind of just go through these bullets very quickly. And then my goal here is to kind of just take your questions, because I think so much is changing so fast with COVID-19. Anything I put in print here, it's going to change. And I don't want people to accidentally pull up these presentations later on and go, wait, something is not right here because LJ said this, but isn't this happening now? So I'm going to just kind of give you a quick highlight right now, and then we'll take questions on COVID-19. Pediatric indication. I believe this will be the way out for many of us. We need to be vaccinating our children against COVID-19. So we all know that there's an indication for vaccinating children 5 years of age and older. That's currently, the data is the clinical trial is ongoing. My update on this is that we hope to have the data from that clinical trial, from everything I've heard, in October. And once that data is available in October, you can bet that the FDA is going to look at that to think about how do we add that to either the licensure or to the emergency use authorization. And I do honestly believe that we have to get pediatrics vaccinated in order to completely get us out of this COVID-19 pandemic. Third doses. So a lot of you have heard about third doses. You've heard, people, the White House talk about September 20th as a potential date for third doses. So yes, there is definitely data that suggests that giving a third dose between, after 6 months from the second dose will improve the immune response such that it is strong enough to cover the variants. And so that's something that's incredibly important for us to think about. And so I think that's the other component to getting us out of this: pediatric indication and a third dose of vaccine. But that being said, we want to make sure that the data is well looked at. That's why the FDA is going to be looking at this data. I believe probably this Friday there is a VRBPAC meeting that's scheduled. And then the ACIP obviously will also look at this data to decide how the recommendation for a third dose, if there is one, is going to be made. So I think obviously you already know that third doses are already recommended for those who are immunocompromised. And so I think this will be for a population beyond that, of course. So I think that's something to keep in mind, and we'll see where that goes. Emerging variants, you've heard of Mu, you've heard of Lambda. What I want to point out is that these emerging variants so far are variants of interest, not of variants of concern. Delta continues to outcompete these variants. In other words, these variants don't seem to be able to compete in terms of transmission as fast as Delta. So therefore, they tend to be more behind. They're not exploding because Delta dominates. And what we do seem to think, looking at some of the mutations in these, like for example, the Mu variant, is that while there may be a little reduction in terms of vaccine effectiveness, like the Delta, we do not believe that it's going to impact vaccine effectiveness to the point where the vaccine is useless. And indeed, the third dose, because of what it does in terms of boosting the strength of the antibody response, may overcome some of these variants in terms of the way they're escaping the vaccine a little bit. Differences between COVID-19 vaccines. So this is something that a lot of people are asking, which one should I get, I think the one that you get, the one COVID-19 vaccine that you should get is the one that you can get into your arms as soon as possible. So, I mean, there are data published out there about how one vaccine may be more cross-reactive against, for example, the Delta variant than another. But again, all the vaccines work against these variants to different extents, and the vaccine you can get into your arm is definitely the one that you should be thinking about. Vaccines in the pipeline, there are new other COVID-19 vaccines in the pipeline. Many of them obviously are now behind in terms of competing up with the 3 that are out there already. There is one that has a lot of optimism associated because of its high cross-reactivity with some of the variants. However, that company's vaccine is still in the FDA approval process with regards to their factory facilities. And so stay tuned on that vaccine, on vaccines in the pipeline as well. Many of you heard about the White House 6-point plan that was released on Thursday. I have to say, if you look at that plan and the impact that it has on the number of people, if that plan can be executed, it will make a severe dent in our pandemic in the United States. I will say that again. If that plan can be implemented as it is written, it will make a dent in our pandemic. Of course, the question as to how it's going to be implemented remains one of those challenges that we're going to have to figure out as we go forward. Vaccine hesitancy. I want to point out there's a lot of misinformation about COVID-19 vaccines out there, from making you magnetic to people trying to genetically engineer data to make a virus that's stronger, to infertility, to a whole bunch of misinformation is out there, and I think it has led to a lot of vaccine hesitancy regarding COVID-19 vaccine. Our goal, obviously, is to try to correct that misinformation and help make sure science wins the day, but also to make sure that a lot of this vaccine hesitancy doesn't pour over into things like the flu vaccine or to other adult vaccines, where we know that it's so important to prevent these diseases from people, even as COVID-19 continues to rage on. So I'm going to stop there. We have about 15 minutes for questions and answers. And so I'm going to go ahead and stop there and say, if you have a question, happy to take those questions. And then I'm going to turn it over to the moderator. Thank you all so very much for your attention. And that's my thank you slide.
Thank you, Dr. Tan. And yeah, just a reminder, if you have any questions, you can submit them on the questions pane. Just type it into that chat box and we'll be sure to address. I have one, Dr. Tan. So somebody had asked, understood you can get the flu vaccine and the COVID vaccine at the same time, but what about the Shingrix and COVID vaccine, or even like a pneumonia vaccine, or has it only been approved you can co-administer flu and COVID?
No, so CDC says that COVID-19 vaccines can be co-administered with any other adult vaccine. Okay. So there is, yeah. So you just and there's a whole list of guidance on how to do that, but that's very clinician oriented, so I didn't present on that. But the answer to the question is any other adult vaccine can be co-administered with COVID-19.
Okay. Next question is around the storage requirements for the vaccines. Obviously, this was a big topic at the start of the vaccine rollout, and they've loosened up a bit with Moderna and Pfizer having some stability at refrigeration temperatures. Do you anticipate any further changes in the short term to the requirements for Pfizer or Moderna?
In the short term, probably not. I think many of you are already aware that Pfizer moved to that smaller size packaging of 450 doses, and then they ran out of that, and so now they're back to some of the larger packs. And so reminding everybody, that in the larger packs, the vaccines go for 6 to 9 months in ultra low temperature, so that's probably of relevance to some of you, up to 4 weeks in the freezer, and then it goes into a fridge. If it goes into a fridge, it's 31 days. So I think it's something to kind of keep in mind that the 975 packaging is back, and that may lead to more folks needing to kind of do better storage with the Pfizer vaccine. But other than that, I do not anticipate any significant changes to the storage and handling for any of the vaccines that are either licensed or on emergency use authorization. The reason for that is right now the emphasis is on obviously looking for data to ensure protection against Delta, and then also obviously in terms of capacity building, because one of the only ways we're going to get to this is to think about those third doses, obviously, and then the pediatric indication. So a lot of the manufacturers are focusing on capacity production right now. I hope that helps.
Yeah, definitely. Okay, last question. So in terms of the mRNA technology, do you anticipate any new vaccines coming soon, or even potentially a COVID flu vaccine on the horizon?
So no, I know there's a lot of rumor out there about a combo flu COVID-19 vaccine, and that there's a manufacturer out outside the United States who's looking at that. So absolutely, at some point, I envision we will be looking at combo flu COVID-19 vaccines. But I think right now it's premature to even think that we have something on the horizon with that. I think a lot of the manufacturers are going to probably take a look and see how COVID-19 continues to play out with the third dose before they make a a decision as to really moving into some kind of combination vaccine. Of course, as providers, a lot of the providers are hoping that that's something that will come up because it's so much easier to give a combination vaccine. But that process would then require a lot of a clinical trial because because you're going to have to look at potential interference between the flu versus the COVID-19 and so on and so forth. And then the other part of the question was mRNA technology. Indeed, this has turned out to be an incredible technology. I want to remind everybody that mRNA technology is not spanking new. We've been using it for at least 2 decades now. We've been looking and doing research. And in fact, if you remember the very first SARS outbreak and the MERS outbreaks, those opportunities led to actual development of vaccines to those viruses that were never used because they disappeared, the viruses disappeared. But we've had a lot of research and development history in the mRNA platform. And I think and because of that, and because of the dramatic success that we have now seen with COVID-19 vaccination, you can bet that we're going to be looking at the mRNA platform for new vaccines. And again, the nimbleness of the mRNA platform obviously allows us to think about being able to kind of generate vaccines changing quickly, right, as necessary. So, if for example, we discover that these variant pops up that indeed is now totally able to totally evade the immune system, because of the nimbleness of the mRNA technology, we can react and create a brand new vaccine against that new variant fairly rapidly. And so I think those are all the great things that we're looking at with the mRNA technology. Again, we know that platforms may look really, really promising, but we still don't know when we start putting in other viruses or other bacteria into that platform to generate a vaccine against those new viruses or new bacteria. We don't know if that technology will translate to equivalent efficiency and effectiveness against those new strains or those new viruses and bacteria. So again, we'll still have to do our clinical trials. That has not changed, but it is exciting to have new technology out there that we can fall back on.
Great, thank you, Dr. Tan. So I'd like to thank you and everybody else for participating in our webinar today. If you have any feedback or comments on the program, you can reach out to me. My email address is kyawit@helmerinc.com. That's KYAWIT@helmerinc.com. All registrants of this webinar will also receive a survey, and we hope to follow up with today's event with additional webinars and topics based on your feedback. So this concludes today's webinar. Thanks again, and thank you, Dr. Tan.